Good evening, everyone, and welcome to the webinar on Biomarkers in Breast Cancer, Current Practices, Opportunities, and Unmet Needs. It gives me great pleasure to invite our moderator, Dr. Vinay Bhatia, PhD Head Molecular Biology and Genomics on Breast Laboratories, Gurugram, to moderate the webinar. Over to you, ma'am.
Thank you so much, Himanshi. Good evening, everyone. On behalf of Oncos Laboratories, I would like to welcome you all in today's webinar. In cancer, precision medicine uses specific information about a person's tumor to help make a diagnosis, plan treatment, find out how well treatment is working, or make a prognosis. Precision medicine for breast cancer is the path to truly personalized diagnosis and treatment. About 5 to 10% of breast cancer cases are due to a hereditary predisposition. In most of these cases, mutations are found in well-characterized genes such as BRCA1, BRCA2, Chacko, TP53, PALB2, and so on and so forth, out of which BRCA1 and BRCA2 are the most important ones. The availability of PARP inhibitors or drugs that are selectively active in BRCA1, BRCA2 associated breast cancer patients has created the need for genetic or hereditary cancer testing for all the patients diagnosed with advanced breast cancer. So genomic profiling, which is the need of the hour, which is basically most of the times it is microarray based gene expression for molecular subtyping, and for disease recurrence prediction is the standard of care in the management of advanced breast cancer. We would be listening more on precision medicine from our esteemed speakers in today's session. So without wasting more time, I would like to invite our first speaker of the day, Dr. Gale Kathleen. Dr. Gale is heading Bangalore operations of Oncos Laboratories. So over to you, Dr. Gale.
Yeah. Good evening, Dr. Vinay, and good evening to everyone present here. And I extend a warm welcome to all my colleagues here who have agreed so happily to share their time with us and share their knowledge with us on this platform. So firstly, I will be talking about the morphological overview of breast cancer and its shortcomings. So this is fairly a very vast subject. As we know, breast is very, very large. It's not easy to complete it in the 20 minutes that we are given, but what I would like to share is the most important points that young pathologists or young clinicians should look forward to while assessing breast tumors. Firstly, the tumor burden. So as we all know, this is 24% of all female cancers. It's the globally most recognized cancers of all, and most females almost always 24% of the time we are going to see a breast cancer, and it is the leading cause of female cancer deaths worldwide, 11.6 among both genders when we take both male and female. And can you hear me? Am I audible?
Yeah, Dr. Gale.
Yeah.
Yes, ma'am.
Yeah, and it's one of the most leading causes of death among cancer-related deaths, especially in females. There's an enormous amount of effort which has been translated and trying to put it into research for breast cancers, and some of them we have had a lot of breakthroughs in the recent past. Next slide. So the estimated number of deaths up to 2018, as per the data given by WHO, around 15% of deaths are related to breast cancer alone. And the estimated number of new cases in 2018 worldwide, all cancers, female, all ages, around 24% of those are breast cancers, as compared to other cancers like colorectal, lung, cervix, etc. Next. So the incidence globally, as we can see, the more darkened shaded blue areas are those continents or countries in which there's a larger or more risk factors for breast cancers or more prevalence of breast cancers. As we can see, North America, some countries of Europe and Australia, wherein there are higher incidence of breast cancers among this society. Next. When we see the Indian perspective, the incidence of breast cancer is 13.5%, and recently breast cancer has overtaken cervical cancer as the largest female-related cancer in India. Next. In India in 1990, the cervix was the leading site of cancer, followed by breast cancer. This was as per the registries of Bangalore, Bhopal, Chennai, and Delhi. By the years 2000, 2003, we had seen a reversal scenario in which breast had overtaken other cancers as the leading cause of leading site of cancer in all these registries. So current trends also point out that a higher proportion of the disease is occurring at a younger age in Indian women as compared to the West. The National Cancer Registry Program analyzed data from cancer registries for the period from 1988 to 2013 for changes in the incidence of cancers. All population-based cancer registries have shown a significant increase in the trend of breast cancer. At this point, I would like to say that even there is multifactorial approach to breast cancer. We have seen there is a lot of data which is available, wherein even those countries which are known to be low risk cancer countries, the population that has migrated to either the affluent societies like North America and Europe, generations after 1 or 2 generations, even there they have an increased risk of breast cancer. So it's not only related to India alone, and even when this population migrates to higher cancer risk areas, they also end up having a higher risk. When we look at the age distribution, whites, Black, Hispanic, and Asians and Hispanics are almost at the same age incidence of 45 to 50 years. Next. So as I said before, breast cancers are multifactorial. There is no single factor that is responsible for breast cancer. It's a mixture of all factors together that leads to development of breast cancer. One is increasing age. So the elder, from 45 years onwards, we can see a slight increase or slight risk in development of breast cancers. Obesity, yes, it is a known. There are lots of literature which is available that speaks about high calorie rich foods which have, a higher risk of developing breast cancer. Harmful use of alcohol, family history of breast cancer, which is known 10 to 15% of breast cancers are familial, and it is almost always associated with BRCA1 or 2. History of radiation exposure, reproductive history, early menarche and late few pregnancies, tobacco use, postmenopausal hormone therapy. Next. So the pathogenesis is again controversial. There are many theories which have been put forward, but the most salient or the most important theories which have a lot of evidence are the 2 divergent molecular pathways related to hormone receptors. One is the ER positive pathway, is characterized by gain of 1q, loss of 16q, and the ER negative pathway, which is mostly associated with loss of 13q. Now, the ER positive pathway are mostly associated with those groups of cancers which have a low to intermediate grade morphology, whereas the ER negative pathway is almost always associated with high grade tumors. Next. So the breast cancer pathogenesis, as we can see, the breast stem cells, they differentiate into either the basal cells or the luminal cells. So the basal cells which are here, the basal luminal cells and the luminal cells. From here we get the luminal A, the luminal B cancers, HER2 positive and triple negative. So luminal A cancers and luminal B cancers are most common type of cancers among the breast cancers. They constitute at least 60 to 70% of breast cancers. They have a good prognosis. most often they are ER positive and PR positive. But there is a slight variation. There can be slight exceptions to this rule, wherein 10 to 15% of them may be ER negative, PR negative, and may show an enriched or a positive HER2 name. So the triple negative cancers are again high grade. They are HER2 positive and luminal and ER/PR negative. Next. Hereditary breast and ovarian cancer is a genetic tumor syndrome most commonly caused by germline mutations in BRCA1 and 2. And they mainly encode for proteins involved in DNA double-strand break repair by homologous recombination, one of the critical maintenance mechanisms of DNA integrity. In order to complete this function, the BRCA proteins interact with a host of other molecules, which together form a protein complex. So without a functional BRCA complex, the cell relies on alternate mechanisms for DNA repair, some of which are error-prone and may further contribute to the development of genetic aberrations. Because of this phenomenon, patients with germline BRCA1 and 2 mutations have an increased risk of development of several neoplasms, not only arising in the breast, but also the ovary and fallopian tube. Next. So as we can see, this is the pathogenesis of BRCA-associated breast tumors, and there is a 6 to 10-fold increase of risk for those patients who are BRCA1 and BRCA2 positive to develop breast cancer. This, in combination with several environmental stimulants, will definitely result in breast cancer. Next. So the clinical scenario, what we almost always see is a breast lump. In 85% of cases, the patient would present with a breast lump. Otherwise, it could be nipple abnormalities, either it could be skin malformations or skin abnormalities, fluidy orange appearance. Some very rarely we get patients, with back pain, and then when we do an MRI or radiological imaging, we understand that there is a metastasis on the breast. So unfortunately, in the Indian perspective, most of our cases, most of our patients present in stage 3 or stage 4 because of the prevailing taboo and no awareness regarding breast lumps. Next. So diagnostically, radiology has a very important tool for diagnosing and screening of breast cancers. So ultrasound USG has an overall sensitivity of 53 to 67% and specificity of 89% to 99%. It's the method of choice for women under 40 years. Mammography sensitivity has been reported to vary from 64% to 90% and specificity from 82 to 93%. 5 to 15% may not be visualized, and in such cases, we can use targeted ultrasonography. The false negative rates are very low. So when there is a combination of both ultrasonography or mammography, there is a less likelihood of missing these tumors. In screen populations, spiculated mass with or without calcification is the classic appearance of breast cancer. Atypical appearances are well-circumscribed masses, architectural distortions, cysts, or calcifications alone. So the clinician or the radiologist should always be aware of spiculated masses with calcification, and that is almost always an indication for any kind of invasive diagnostic procedure, either an FNAC or a breast biopsy. So this is a pictogram which is just representative of the spiculated margin over here with some amount of calcification. Most radiological reports would come as a BIRAS category. So you have BIRAS category 0 to 6. And the most important categories among that, which is suggestive of malignancy or highly suspicious of malignancy, is 5 or 4, 5 or 6. And the next available option for these cases which are scoring 5 or 6 is tissue diagnosis. So either a true cut biopsy or a surgical excision based on the clinician. Next. So FNAC again, it's highly sensitive. Up to 97% of the time, we can accurately diagnose these lesions, whether benign or malignant, and group them into a particular category. Nipple discharge cytology is also very sensitive if the region is retroareolar. Fluid cytology or infant cytology is also being tried. So in resource poor settings like in rural areas or in those
Sorry
settings
to interrupt, ma'am. Ma'am, there is some kind of disturbance coming from your end, ma'am. That's why your voice is not clearly audible.
now.
Yes, ma'am. Now it's perfect, ma'am. Thank you.
Yeah. In resource poor settings, cytology comes readily useful. So in those areas, in those regions where there is no MRI setup or there is no surgical oncologist available to do a breast biopsy, combination of ultrasound or the combination of a radiologist and a pathologist there would be really helpful. It would really narrow down and track the diagnosis here at this point, because combination of a radiological report and a pathology FNAC is virtually diagnostic of cancers. Next. So fine needle aspiration cytology is also grouped, like the BIRADS in radiology is also grouped into C1 or C5. There are various systems for reporting breast FNAC, and this is one of the systems based on European USA guidelines. C1 is unsatisfactory, C2 is benign, C3 suspicious. The most important ones are C5 and C4. This would be a necessity to do a tissue diagnosis or an invasive biopsy is must and should for all positive or all FNAC confirmed malignancies. Next. This is another method which is prevalent. Many centers, cancer centers, would use the Massoud and the modified Massoud classification, wherein the scoring is based on monolayering, nuclear overlapping, clustering, discohesion, and so on and so forth. And these scores are then grouped into 3 categories. And based on that, non-proliferative breast disease, proliferative breast disease, and with or without atypia is given. Next. So this is a cytology smear wherein we can see this group of more 3-dimensional clusters of atypical cells at the upper right corner. And then there are some single scattered atypical cells having hyperchromatic nuclei. Few of them are having prominent nucleoli. The background is, go back, please go back. Go back. Yeah. So the background you see is having some amount, there are hardly any bare nuclei in the background, which is a diagnostic, a classical, or one of the characteristics of invasive carcinoma is the absence of bare nuclei. There are some cyst now macrophages. So this is a classical case of invasive ductal carcinoma. Next. This is a case of papillary carcinoma. As you can see, this is a highly cellular aspirate. There is papillary fronding, and there is a nice fibrovascular core. The cells are quite atypical. Next. So the one on your left-hand side, this is, you can see that the tumor cells here are very discohesive. They're not clustered around. They are very atypical. Plasmacytoid eccentric nuclei. This is a case of lobular carcinoma. The one on your right is a case of mucinous carcinoma. The background is showing a lot of mucinous deposits and some atypical cells. Next. So definitely, yes, there are some pros and cons to FNAC. The most important, we will not be able to differentiate invasive carcinoma from ductal carcinoma in situ. That is a tissue diagnosis. So this is one point that FNAC will not be able to help. It is a screening test, and it doesn't usually provide a specific diagnosis. It can just tell you whether it's benign or malignant. And that is a starting point for any treatment. Next. The next is the latest WHO classification. So I don't want to get too into this right now. What is the most important thing in WHO classification, in the latest WHO classification? Go to the next slide. The next. Yeah. So this, there are some major changes in the recently released WHO classification of breast cancers that was in 2018-2019. And here mitotic counts are not now expressed as 10 hyparches, but as given as squares based on the diameter of the microscope. Then carcinoma with medullary features which was previously a separate entity is now regarded as a TIL rich IDC NST. And what is more important is well differentiated liposarcomas and phylloid tumor. Now this is not regarded as a morphological, no longer a histological criterion of malignancy by itself, because the liposarcoma in phylloids is not shown to show any metastasis and no recurrence. So by default, that is not a malignancy. And mucinous cyst adenocarcinoma again. So that was initially not recognized as a separate entity, but now WHO has given it a new entity. And the tall cell variant or the tall cell carcinoma with reverse polarity is now grouped under the papillary thyroid carcinoma or solid papillary carcinoma. Reverse polarity has a separate grouping structure. Next. So DCIS is one of the most important or common occurrences that we see in routine screening of breast tissue. And these cases can present as palpable mass, nipple discharge, or Paget's disease of the nipple. And 20% of screen detectable breast cancers are DCIS alone. And 85% can be detected mammographically as calcification. So there is one case detected per 1,000 screenings. So we need to up our screenings at this point to diagnose more cancers. 50% recur as invasive malignancy, and 22% of women develop invasive malignancy in contralateral breast. So DCIS again is graded as low, intermediate, and high grade. And histological report should mention the grade, presence or absence of necrosis, architectural pattern, size of the lesion, and distance to the closest surgical margin. Next. So this is a histological slide that is representative. The upper right one is a low-grade DCIS. The one in the middle or just below that is intermediate grade, and this is the high grade. So in the high grade DCIS, it's based on the nuclear cytomorphology, presence or absence of necrosis. So in the high grade lesion, you can see there is vast areas of necrosis. The cells appear highly atypical or ugly looking, and they have loss of polarity. There is a lot of hypochromasia and brisk mitosis. Next. Yeah. So these are the patterns of DCIS where we would come across in daily screenings of our histopathology slides. Most commonly the classical pattern, the cribiform pattern, the micropapillary pattern, apocrine changes in DCIS, and even a comedotype or necrosis. Next. So invasive breast carcinoma, again the ductal type. Many of our pathology reports would have the modified Bloom-Richardson grading system, which is based on tubule and gland formation percentage, nuclear pleomorphism, and mitotic count. So the tubule and gland percentage, if the majority of the tumor is more than 75% of it is tubule, a score of 1 is given, and subsequently, if there with the tumor tubule formation reducing, the score also increases. Inversely increases. If the tumor is arranged in sheets with no proper tubular differentiation, then the score is 3. Similarly, with nuclear pleomorphism, based on mild, moderate, and marked variation, scores are given as 1, 2, 3, and mitotic count depending on their area assessed and the diameter of the field. Next. This is the Nottingham grading principle for nuclear pleomorphism. As you can see, the first one, you are having cells which are having rather bland nuclei, hardly any nuclear pleomorphism, really no hyperchromasia and no prominent nucleoli. There are hardly any mitotic figures here. Whereas the second, there is a gradual change in which there are few tubules, also there are few sheets of cells. So this comes under the category 2. And also the pleomorphism and mitotic activity is slightly more than what we saw in grade 1. And marked variation in size is the third, wherein there is marked pleomorphism. There can be bizarre cells, hyperchromasia, prominent nucleoli, brisk mitosis, necrosis. This comes under the score 3. Next.
Sorry to disturb you in between, Dr. Gale. We had already exceeded our time slot given. So if you can quickly, thanks.
Can we go to the end? Yeah, this is a morphological interpretation of different types of cancers that we are going to come, in touch with. Next. So these are new entities like mucinous adenocarcinomas, which I have already explained. Next. 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 Yeah, next. 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 Yeah. So this is an important thing I think everyone will be aware of, is the molecular classifications: luminal A, luminal B, luminal B like, which is HER2 positive, and HER2 and triple negative. Next. Next. Yeah, so the WHO recommends, we get a lot of cases wherein which comes in for second opinion, in which these are triple negative tumors and ER and PR are all negative. But when we look at the slide again, there is 1 to 10% or very few percentage of cells which take up a very weak staining of ER. In those cases, we need to give it as low positive. So these patients will definitely benefit from endocrine therapy. So always, almost everyone should look at the high power view of these ER positive slides or ER slides and look for weak staining in the breast tissue. Next. So there are a lot of guidelines for ER, PR, HER2/neu, and all our reports would mention that. Next. Next. Yeah. So the luminal, this is the immunohistochemical expression of luminal A, luminal B, HER2/neu, and basal-like type of expression of all IHC markers in these in the morphological types of breast cancer. Next. Yeah. So the prognosis is also related to these expressions. As you can see, HER2 positive, ER positive, PR positive are all having a good prognosis as compared to triple negative markers. Breast tumors. Next. Next. The latest one is the PDL1 expression, wherein PDL1 expression with more than 1% of its tumor has a very good prognosis as per the latest literature which is now available. Yeah, with this, I'd like to end, and thank you very much for giving me this opportunity. Thank you.
Thank you so much, Dr. Gale, for the wonderful session on morphological overview on breast cancer. I would be requesting to all the attendees to type their queries in the chat box so that we can take up all the queries afterwards, after the session, in QA session. So the next speaker of the evening is Dr. Atul Samaiya, who is Senior Consultant Surgical Oncology and Bansal Hospital, Bhopal. Over to you, Dr. Samaiya.
A very good evening to all. This is very interesting topic. Basically, challenges in the breast cancer management in India, especially the early breast cancer. Please, slides, so please. Next, please. Part of my job is already done by Dr. Kathleen, and she has mentioned about the rising incidence of breast cancer in world, especially in developing countries like India. And we have definitely the number of breast cancer cases are rising very rapidly, almost 3% per year. Next, please. The reason, as he already mentioned, in summary, we can say it is the urbanization or westernization effect of the social life or our life that is leading to changing in lifestyle and food habits. Ultimately, it is a major cause for the breast cancer, especially in the urban registry. If you see the Varsi Rural Registry of India, cervical cancer is still the most common cancer in the females, unlike in the all urban registry, it is the breast cancer. But if you see the mortality and incidence ratio, rural registry is very high, 66 versus almost 8 in as low as 8 in the urban registry. Next, please. This is almost 13.5% incidence of breast cancer and accounting for almost more than 10% mortality of all cancer. Next, please. Next. The important thing, previous one, please. Yeah. Important thing, if you see the Western world, we take the America as the standard, and the incidence is much high compared to India, almost 120 million cases per million. And compared to India, which have an incidence is almost 80. But if you see the mortality is much higher in India or other Western countries compared to other Western countries, and the incidence there relatively low, though their incidence are rising rapidly, and very soon, maybe in the next decade, we will be reaching somewhere here. So the important thing, we are having less number of cases compared to Western world, but still the mortality is quite high. Next, please. The reason is almost 60% of our breast cancers are diagnosed at stage 3 and 4. And second important thing is that we are seeing much younger patient compared to Western world. If you see the Western world, the average age of onset is almost 55, 60 years. But if you see India, it's around 45, 44 years. So the younger the patient, more chances of developing breast cancer in our country compared to the West. So it is a big challenge because the younger patient have a dense breast, the mammography not able to detect a smaller lesion in the dense breast, even the larger lesion sometimes in the dense breast. And the palpation lead to many times lumpiness or nodularity, and this nodularity sometimes mixed with the breast cancer. So it is a real challenge.
Atul, your voice is not clear. I believe there is some disturbance.
Yeah. Next slide, please. So if you see, this is almost 25 years back, we have a more patient and age of 50 to 60 years of age. And now if you see presently, the majority of the patient is 30 to 50 years of age. So this is a changing or reversing trend in India, and maybe due to a change in the rapid change in our habits and westernization. Next, please. So there are so many challenges. If we have seen the prevalence and incidence of breast cancer in India, there are so many challenges for early diagnosis and treatment. If you see the challenges I have mentioned here, there is no mass screening program in India. There is lack of awareness. There is lack of facilities for early diagnosis. There are so many social taboos and stigma. There are financial and social constraints. Access to treatment facilities are limited, and lack of social support system compared to West. So I will discuss one by one each of them. Next, please. Next. No screening program. We have a large population, very difficult to cover on mass screening. There is a huge cost involved in the mass screening. And then screening standard method is mammography, which is very limitedly available. Few government setup have mammography units, except the last center and cancer units. If you see, even in whole central India, Madhya Pradesh, there is none of the medical colleges have mammography unit in government setup. Even if mammography is available at some smaller town or secret town, there and
Dr. Atul, can you
Dr. Atul, yeah,
yeah,
your voice is not clear, Dr. Atul.
it's not clear in between, or it's not coming
In
at all.
between, Dr.
Okay.
Atul, in between it is going. Yeah.
Okay. Previous one, please. Previous slide, please. Previous one. So, if these lesions are found, next one, please. If we found some lesion on the breast screening program, then what to do next? Biopsy, guided biopsy, MRI. Again, the facilities are limited. So even if we are able to do screening by mammography and certain high-risk patient, the facilities for further investigations are limited, and how to proceed is a challenge. There is alternative to mammography. I will discuss it later on: breast self-examination and clinical breast examination. Next, please. The second point is lack of awareness. Lack of awareness is there in general population as well as in the healthcare professionals. People are not aware that there is cancer-like disease and the person may suffer from cancer, especially in the rural area. Though with increasing social media, increasing awareness due to the print media, and people are more aware due to internet, even in the rural areas, people have better awareness compared to 10 years back. And most of the time, females ignore the minor symptoms because the cancer initially do not start with the pain, and they ignore that this lump or whatever problems he is feeling, maybe nipple discharge, is not due to cancer. And many times we have seen the patient presenting like third stage, or sometimes even the large fungating mass, fourth stage. Next, please. Even we always talk, previous one, please. We always talk of awareness of general population or the patients, but even our health professionals are not very much aware of the cancer. What are the risk factors and how to diagnose breast cancer at early stage. So when even the patient presenting with symptoms to a healthcare professional whom they are contacting regularly, they may not able to diagnose the breast cancer at early stage. And even in our medical education, there are very less focus given on the cancer diagnosis and its management. And this is a need of our. Next, please. If patient presented with the lump, somebody has diagnosed, some patient is very much aware of the breast symptoms, cancer of the breast, and they come to know that this may probably have a cancer. So they go for the early diagnosis. But unfortunately, the facilities for early diagnosis are limited. Next, please. We have limited facility for pathology. We have limited facility for the neonatal biopsy. And if you see the district level hospital, there is nobody to do neonatal biopsy. The ultrasound facility is limited. Mammography is not available to confirm or refute the diagnosis whether patient have a lump which is due to cystic formation or due to nodularity, or it is a truly cancer. And ultrasound is one of the tools which is relatively available in the smaller town, but the problem is it is very much operator dependent and they may miss small lesions. So even we know this patient may have cancer presented with the early symptoms, but due to lack of professional to perform biopsy or further investigate, we are missing the early diagnosis. Next, please. And one study conducted by Gangane in 2016, and they found there is average delay of 3 months in the diagnosis and treatment in almost 1/4 of the patient. And second is the provider's delay. Provider delay is because of the lack of awareness of the health professionals or due to lack of facilities like mammography and biopsy. And it was found in rural areas, the delay from the provider side was almost 80 days and 66 days in the urban areas. So again, making a delay in diagnosis. Next, please. Then come to social taboo and stigma related to breast cancer and other cancer. Next, please. Breast is a private organ, and patients are very much concerned and they don't want to reveal anything about the breast. And it is a big embarrassment for the patient and their family. So female or women, they feel in isolation. They think if they reveal somebody has a cancer or they have a lump or it may be cancer, the society will feel about bad. And many people especially in the villages or the rural areas, they think cancer is a contagious disease, so it can spread. And if the woman found that she has a lump, it could be cancer, and so she is worried about disclosing this to family, even the family members. Otherwise, she will be isolated. So the fear of isolation lead to delay in discussing the problems with the family, and there is delay in diagnosis. And sometimes, if even the family is supportive, they come to know that their reputation will suffer because in some people still consider the cancer is because of bad karma and it is a contagious disease, so family may be isolated and their daughter or son may get problem wedding or marrying, and that's lead to delay in diagnosis. And when the patient become very much symptomatic, fungating mass happens or the bone pain start, dyspnea start due to lung metastasis, they come to the clinic. Another common myth about the cancer is biopsy lead to rapid cancer or rapid spread of cancer. And because of this, many patients, even they know, they come for consultation, they consult a doctor and then biopsy is advised. They defer the biopsy in the fear that if they get the biopsy, it will spread rapidly and society, cancer is considered death sentence. They think it is not curable. It is a these are the social stigmas and social challenges we are facing with the breast cancer. Next, please. Another problem is financial and social constraint in the diagnosis and treatment. Next. Many times the people lack trust in the healthcare provider. They trust alternative medicine people because they give the guarantee for the cure of the breast cancer or any other cancer. So many times they waste a lot of time taking alternative medicines and avoiding the diagnosis or delaying the diagnosis because they give them a trust and assurance that cancer is curable by only alternative medicine, not by the allopathic medicine. Another problem is as we have discussed, the facilities are limited to metros. Now they are coming in the big great towns, so they have to travel. The traveling cost is involved. There is a problem with the transport. There is a access to service. So they have to plan. They have to take leave from their routine work. Then only they go to cancer center. So it is a whole problem for family. If they want to get diagnosis early, they have to plan so many things. They have to plan their travel. They have to plan arrangement for the kids, small and other family members who can take care of them. And then only they can go to travel. And once they are traveling to a cancer center, once we say it's possibly cancer, we need further investigation. Again, and we have to do a biopsy. Biopsy will take another 4 or 5 days to come. They have to come again. And many times after biopsy, we lose the track because the patient was not able to come again and again to hospital for the treatment. So this is because of the financial and social constraints to patients, and the diagnosis is delayed. If the patient is coming with the because generally patient is attended by 1 or 2 family members. If they are coming, they are losing their wages, they are absent from workplace, so financial losses are there. So they try to take a quick relief from a quack or the somebody who is practicing nearby and take alternative medicine. They misguide them and the diagnosis of cancer is delayed, and so the treatment. Next, please. Then our healthcare is very inadequate and fragmented. There is high attrition or loss of follow-up early cancer, breast cancer treatment due to the out-of-pocket expenditure, financial constraints, as I have already discussed. If somebody is taking a cancer treatment in a private setup, almost 3 times costlier than the government setup, and almost 20% household income is expended on the breast cancer treatment, and many patients, and that is a catastrophic for a average middle class or no middle class family. So there are financial and social constraints for taking early diagnosis and treatment of breast cancer. Next, please. May I? Then access to treatment, unequal distribution of cancer centers. Next, please. All we know, there is a large variation of healthcare standard. We have a world-class facilities available in metros like Mumbai and Delhi, but we have a very poor class facility treated by patient, treated by non-oncologists in a non-standard manner, and mismanagement of breast cancer. So again, the treatment outcomes are poor. Next, please. As per the reports, we have only 2,000 oncologists for 10 million patients. But as per the guidelines, we need many more patients, many more trained oncologists to treat our country, the huge number of population. And even if the number is 2,000, majority are concentrated in metros and urban areas, and our population lives, almost 60-70% population lives in the rural areas, but the facilities, 95% facilities are focused in the urban area. So there is a lot of differentiation or the lot of variation in our cancer care providers. Even there is a regional variation. If you see the south and the western part have a more cancer centers or better cancer care compared to the northern central and eastern India. So though facilities are available, we are providing world-class treatment in many metros, but if you go to a semi-urban area or the rural area, the facilities are very, very limited. Next, please. As per recent study, India has just 10% of the total requirement of radiation therapy, and radiation therapy is one of the very important part of the breast cancer treatment and management. So we have almost 4,500 machines are lacking. Unfortunately, even these machines which are centered in the metros. So there are pitfalls of many radiation units, the pitfalls for infrastructure. There are so many patients, they are going without treatment for radiotherapy because they have to stay long for the radiation treatment. They have to come away from their home. The completion of treatment many times is not there in the breast cancer patients. Next, please.
Dr. Atul, sorry to disturb you in between. We have another 2 to 3 minutes for this session.
Yeah, I'm just completing in 2-3 minutes only. And compared to the Western world, we have a very poor survival because of the late diagnosis, early onset, early age of onset, and delay in the definite treatment and costly treatment. Next, please. The Cancer treatment need a multidisciplinary MDT treatment within surgery, chemotherapy, target therapy, and radiotherapy. The surgery, mastectomy, oncoplasty, sentinel lymph node biopsy. Unfortunately, many patients are treated by a local surgeon who are doing mastectomy, incomplete mastectomy. When the breast conservation surgery should be a standard of care for early breast cancer, but it is lacking. Next, please. Many patients, they don't want surgery. There is fear of surgery. The surgery will lead to spread of cancer. Surgery is done in form of lumpectomy, which is incomplete treatment. And patient assure that, okay, your surgery is done, your lump is out, the treatment is over, which is not. And that lead to early recurrences and metastasis. Next, please. Majority, as I have discussed, only 30% are going for breast cancer, breast conservation surgery. Remaining are going for mastectomy. They fear for recurrence. There are social and financial constraints for radiation, and there is lack of trained oncoplastic surgeon to perform conservation surgery. Next, please. Sentinel lymph node biopsy is the standard of care for early breast cancer, not performed even in many cancer centers because, again, there is lack of professional, lack of surgeons who are trained. There is lack of nuclear medicine facility and frozen section facility. So many patients are going unnecessary axillary dissection, leading to lymphedema and seroma formation. Next, please. We all know about the problem with chemotherapy, toxicities, lack of support system to manage toxicity, and many patients drop out, and we don't have it easily available.
Audible, Dr. Atul?
Next, please. The problem of radiation is already discussed. Next, please. So how to overcome these challenges? The most important thing is awareness. There is TV, internet, newspapers, social media, cultural gathering. All these can help in awareness of breast cancer. We have to train our health professional. We have to modify our medical curriculum. In the clinical breast examination and breast self-examination, we have to teach patients that breast self-examination, one of the way to diagnose early stage cancer. Apart from it has to be regular, supported by clinical breast examination by health professional. And we have to develop a social support system. Next, please. Next. For training of health professional, we need a workshop, CME, change in teaching curriculum. We have to demonstrate them. And this is very important. Until our healthcare professionals are aware about the disease, we cannot make a change in the society for early diagnosis. Next, please. There is a study by Mithun et al. Clinical breast examination is very effective in Indian patients. So breast self-examination should be taught to each and every female after age of 20 years. And after the period of menstruation, they have to start their examination monthly, and we can detect some of the cases early. Next, please. This is the breast examination, clinical and self-examination. Next, please. Next. 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 So how to overcome these challenges? Rising human costs, social and economic factors. We need a more holistic and multidisciplinary approach, multidimensional approach to encompass the cancer care continuum, including prevention, early diagnosis, and treatment. A balanced approach is necessary. Next, please. Thank you.
Thank you so much, Dr. Atul, for highlighting the challenges associated with early diagnosis and treatment, specifically in Indian scenario. So the next speaker is Mr. Joe McKelley, who is working as Vice President of Vice President Market Development and Innovation Age India. Mr. Joe would be sharing his experiences of precision medicine, therapeutics, and new methods in breast cancer diagnosis. So I welcome Mr. Joe. Over to you.
Great, thank you for that introduction. Let me go ahead and share my screen here. and hopefully you're able to see the screen.
Yes, sir.
Yeah, it's visible.
Okay, perfect. So thank you for the opportunity to present on this important topic, and thank you to the previous speakers for such a great overview of the experiences with breast cancer diagnosis and the current challenges. So really, the purpose of my talk here today is to really talk through the importance of precision medicine and how testing with genomic information can help really enhance the care delivered for all your breast cancer patients. So my disclosure is, of course, that I am an employee of Agendia. So I think what I wanted to start off with is to really highlight the need for, or why these genomic tests were created in the first place. And I think Dr. Samaiya really talked about some of the challenges that are associated with breast cancer care, and it really highlights the need for tests like MammaPrint Blueprint to help meet this challenge. And that's really this topic is, or the problem in breast cancer care largely has been to produce unnecessary chemotherapy treatment. There was a tremendous problem of overtreatment of patients early on in breast cancer, and that was really highlighted by this information here. But what we saw is that for all breast cancer patients, there was this benefit of chemotherapy that was seen. So the standard of care early on for breast cancer, starting in the late maybe early 90s, is that every breast cancer patient was really destined for chemotherapy, and that was based off of really a small benefit that was seen for the entire population. But really, what was oftentimes overlooked is the number of patients that did well without chemotherapy, and that's highlighted here. The benefit was about 4%, but really what we saw is about 88% of all breast cancer patients did well, or had a 10-year recurrence-free survival with only endocrine therapy alone. And really what that was a signal was there is this large population of luminal breast cancers that can do well without chemotherapy. So the purpose of genomic tests is to really precisely identify these robust and reliable matter. So again, the purpose of these tests is to help de-escalate the use of chemotherapy. And I think that can help overcome a lot of the challenges that are perceived with breast cancer care. But really, what I want to highlight is, bringing it back to the patient. This is really a tough decision, a challenge that you clinicians face every day. For instance, with a 61-year-old female, 2.1 centimeter grade 2 tumor, ER positive, PR positive, HER2 negative, lymph node negative. Really, the question is, well, can this patient omit chemotherapy? And then that really should be the driving question for determining her breast cancer management. And what we learned earlier today is, we know the clinical features of this patient's tumor, the tumor size, the grade, the hormone receptor status. But really what we want to understand is, or really what we want to explore is what the biology can tell us, and that's the underlying biology that is being uncovered with a test like MammaPrint. So what I wanted to focus on was the development of MammaPrint and how this really sets us up for understanding the underlying biology of what's going on with these with breast cancers. And what's unique about MammaPrint is the methodology and how it was developed. So really what we used was tumor biology to inform the selection or the creation of these 70 genes. And the way that this was achieved was to take a large biobank of untreated tumor samples. So this is tumors that had taken a biopsy, and these patients were actually untreated for about 20 years of follow-up. So what we were able to see is really a pure prognosis of patients by dividing these tumors into two groups: those patients that had no recurrence within 5 years, and those patients that did have a recurrence within 5 years. And then what we did was we took really early machine learning or artificial intelligence to identify by looking at all the transcriptome the whole human genome to identify the most important genes for predicting this metastatic recurrence. And the output of that was the 70 genes of MammaPrint. Interesting at the time is that the top 70 genes that were predicting this metastatic event, ER, PR, HER2, and Ki67, were not among the top 70 of these important genes. And I think at first that was a peculiar finding, but when you think about it, for instance, for a HER2 negative patient, the presence or absence of HER2 expression isn't really important. It's not driving a decision for giving a trastuzumab for that HER2 negative patient. So from a prognostic perspective, it doesn't provide a lot of precision in determining if a patient is going to have a metastasis. And for ER and PR, that's almost 75 to 80% of all breast cancer patients are luminal. But really, there's no precision in determining which one of those luminal patients can recur. So that really highlights what you need to look at is a deeper level of biology to understand what is the metastatic potential for our breast cancer. And so these 70 genes, when we overlay them into the hallmarks of cancer, or really the 7 critical steps of metastasis, what we see is that the mammaprint genes cover all 7 of these critical steps. So what you're really seeing is the metastatic potential of a tumor, and that mammaprint can meaningfully measure this potential. The data behind mammaprint is extensive. There's quite a bit of validation for the test. So we have over 20,000 patients in all of our validation studies, and they range really across the continuum of care, whether it's chemotherapy prediction, prognosis, neoadjuvant or preoperative decision-making, early endocrine management, extended endocrine management, and molecular subtyping, which is one of the topics that I'll speak to in detail. So mammaprint does measure is measured off of an index. So it is looking at continuous biology, but the unique aspect of it is that it provides a definitive result, splitting the results into either a high risk or a low risk. And what you see is that there is a continuous index that ranges from -1, which is the highest of the highs, all the way to +1, which is the lowest of the lows. And so based off of the low and high risk, we're able to distinguish our two patient groups, those that have low metastatic potential from those that have high metastatic potential. And really that dictates the response to chemotherapy, whether you're low, really no response. If you're high, then there's an increased response to chemotherapy. And what we're now looking at is within these 2 categories, we're further defining breast cancers, adding more precision by identifying really 2 additional subgroups within the low and the high. On the low risk side, we're identifying this ultra low risk group. And these are patients that have a mammaprint index of greater than 0.355. And these tumors have really excellent survival, even 20 years out, really low metastatic potential. And what we're seeing here is really an indolent type of biology where even endocrine therapy may be de-escalated for these patients. On the opposite side, for high-risk patients, what we're identifying is really these extreme responders to neoadjuvant chemotherapy, as well as now novel agents. And we'll look at some data at a high level, really what the benefit of identifying these ultra high-risk patients is for your breast cancer management. So what we've been able to show is that these 2 groups have consistently identified low risk and high risk biology, and that's regardless of treatment. So even in our earlier validations, these are all patients who received really no systemic therapy, so just surgery alone. And you can see clearly is that there's 2 distinct groups: a low risk group that has a 90% recurrence-free survival, a distant recurrence-free survival at 10 years, compared to a high risk group that has a 71% estimated distant metastasis-free survival at 10 years. And again, this is without any endocrine therapy at all either. Now, when you fast forward and look at the prospective randomized MINDAC data over almost 7,000 patients, what we see is that even with the addition of endocrine therapy, again, you're identifying these 2 distinct groups of patients, low risk biology versus high risk biology. So one additional aspect of the test is again to help inform the chemotherapy prediction for a mammaprint test. So what we can see is that for mammaprint patients that are high risk, you see that this predicts almost a 12% absolute benefit for the addition of chemotherapy in addition to endocrine therapy. So these are all mammaprint high risk patients, regardless of clinical risk. And then for preoperative use in the neoadjuvant side, what we see is that the higher the risk based off of the mammaprint index, the higher the probability of achieving a pathologic complete response in the neoadjuvant setting. And what I mentioned earlier is now this new category of breast cancer is what is being called ultra high risk. And these are patients that have really an increased response to not only chemotherapy, standard chemotherapy, but also novel agents. So mammaprint is being used in the I-SPY 2 trial in the US. And what this has the ability to do is look at the immediate response within the breast cancer patient for these novel agents. And what we're seeing is that these patients that are classified as mammoprint high 2 or ultra high, they have an extreme sensitivity to standard chemotherapy, but also novel therapies as well. The most recent data supporting this is the analysis looking at durvalumab and olaparib, so immunotherapy. And what we saw is that these patients that are high risk, these are luminal patients actually, that are mammoprint high risk 2 or ultra high, they actually saw this response to this combination therapy as well. You can see here, patients that were mammoprint high 2 had a much higher increased probability of achieving PCR with this therapy compared to the control arm. So again, now really this is the first time what we saw in a luminal cohort of patients, the response to a PARP inhibitor and immunotherapy. So mammoprint is really one piece of the puzzle. The other aspect of a genomic testing that we provide is a test called Blueprint. I think that's really going to highlight the importance of adding genomic testing, looking at the underlying biology. So as we learned earlier, really the 3 main subgroups that is identified within breast cancer are luminal, HER2, and basal, and that is what you're looking at. That is what you're provided with Blueprint. However, we use 80 genes to help determine this, and when you combine mammoprint plus Blueprint together, what you're now able to do is now distinguish really this high risk versus low risk luminal biology, so luminal A versus luminal B. Within the HER2 group, you can distinguish a low risk HER2 type versus a high risk HER2 type. And importantly, what we're going to look at and focus on is this basal type group. But really, the combination of mammoprint Blueprint now allows you to define over 5 different subtypes of ER-positive breast cancer, and that's important because really, when you look at standard tools that are available, it's really a challenge to identify more than 2 groups. So these are the 80 genes. You can see that really this is almost 3 signatures in one. You have a luminal type signature, which is consisted of 58 genes. There's a HER2 type signature, which is consisting of 4 genes, and then a basal type signature, which is consisting of 28 genes. And there's 4 that overlap with mammoprint. So an important data that I want to focus on is the ability to reclassify patients from one subgroup to another. So what I want to highlight here with some data is the clinical utility of Blueprint, and this was demonstrated in the MBreast trial in the US. So this was a trial of almost 1,000 patients, and this was testing on preoperative core biopsy samples. So mammoprint and Blueprint were both tested on a pre-op needle core biopsy. And this was compared to the classification that was provided by clinical subtyping with IHC and FISH. And really the purpose of this test or this trial was to identify what is the impact of having genomic testing in providing a more accurate prognosis or classification. And what we found was that there was almost a 1 in 5 reclassification or discordance between IHC and genomic profiling. And one of the most important discordances that were identified was the ability to reclassify a traditionally ER-positive cancer into a genomically basal subtype. And that's what we'll look at here in a little more detail. So on the left side, this is a great diagram to highlight really how patients flowed from clinical subtyping on the left to genomic subtyping, molecular subtyping on the right. So on the left side here, you can see the classifications: hormone receptor positive, HER2 positive, triple negative. And these are the associated PCR rates with these broad subgroups. But what's important here is that typically, as you'd expect, the ER-positive group has really a low response to chemotherapy and neoadjuvant setting, about 10% as a whole. And really, that there's not a lot of ability to further distinguish a luminal A versus luminal B beyond Ki-67 as a marker. So what you can see here is that when you add the power of Blueprint and mammoprint, you can now really define these patients based off of their response. So you're now able to distinguish this luminal A type with a very low PCR rate. So again, these patients probably can avoid chemotherapy in neoadjuvant setting and go straight to surgery. You have these luminal B patients that have a slightly increased response to neoadjuvant chemotherapy. So maybe a candidate if they want to debulk or have a tumor reduction for a breast conserving therapy versus mastectomy. The HER2 type, which you can see the responses to neoadjuvant chemotherapy are well within what's expected, almost a 73% PCR rate for a confirmed HER2 type. But what's most important is the identification of this group here, an ER-positive group that has almost a 34% chance of PCR in a neoadjuvant setting. And these are patients that are identified as basal-like by Blueprint. So when you look at the reclassification, so out of the 694 patients that are ER positive, almost 13% of them are reclassified as basal-like. Actually, so which was almost 91 patients out of this group. So these are patients that again looked clinically ER positive, but by genomic subtyping, they really have a behavior of a triple negative patient. And you can see here, based off of the height of the bar, this is the observed PCR rate for these patients. So again, for a ER positive patient that's considered or reclassified as basal, they had an observed 34% 34% chance of PCR in the neoadjuvant setting, compared to the overall group of ER positive by clinical subtyping, and now the molecular defined groups of luminal A and luminal B with Biomarker Blueprint. So again, very important to identify this group that is highly responsive to neoadjuvant chemotherapy. And when we look at the total number of patients, is almost 13% of all ER positive breast cancers. When you look at a more higher risk cohort, actually that number increases to almost 1 out of 3. Almost 1 out of 3 patients that are ER positive are reclassified as basal-like by Biomarker Blueprint. And when you look at the ability to use IHC to determine these patients that are possibly basal-like, what we see here is that the ER expression can actually range all the way from 1% to 99%. So these are all patients that that came back as basal-like, even with almost a 99% expression by IHC. PR was a little more informative. It topped out at 50%, but still these patients are clearly ER and PR positive, but then come back as a molecular basal-like. And again, what you see here, when you compare the PCR rates between a true triple negative and the Blueprint basal, you see these are almost equal. So in terms of behavior, these basal-like patients are behaving like a true triple negative in terms of response to neoadjuvant chemotherapy. So what's also important to look at is, well, what is the impact long-term for these patients that are reclassified as basal-like? And what you see here, again, as you'd expect, for those patients that are basal, but then receive neoadjuvant chemotherapy and achieve a PCR, their long-term outcome is quite good, almost 93.7% 5-year DMFS. So that's a great outcome for these triple negative patients if they achieve PCR. Of course, what's concerning are those patients that don't achieve PCR. So for a triple negative patient that doesn't achieve PCR in the upfront setting, their long-term survival is quite poor. So to further look at the impact of the ER positive or the ER positive basal, so those patients that are reclassified as basal-like, again, what you see here is that same distinction. For those patients that achieve PCR, a very good outcome at 5 years compared to a patient that doesn't achieve PCR, which is distinctly different from the traditional ER positive luminal patients. So what are some of the clinical implications of identifying these ER positive basal cancers that really behave like an ER negative basal or triple negative? Really, I think when you look at the application of chemotherapy, oftentimes there is a distinction between a triple negative and a luminal cancer and how they're treated and which chemotherapy regimens they receive. So the ability to identify these in the upfront setting may have an implication or an important decision to be made for their chemotherapy regimen. When we look at the timing of therapy, we know that for triple negative, really the standard of care for these patients, depending on the tumor size, really is that these patients should receive neoadjuvant chemotherapy. Really, we see the long-term benefits of achieving PCR, and we know that the delay of receiving treatment is exacerbated based off of the molecular subtype. And for triple negative patients, they have a much poorer outcome if their treatment is delayed beyond 4 to 8 weeks. So to be able to identify these patients robustly in the upfront setting is important for their long-term care. Again, what we see is the correlation between PCR and in triple negative cancers and long-term outcomes. So a high PCR rate indicates really possibly a good outcome for a patient that's reclassified from ER positive to a basal-like by molecular subtyping. And for those patients that have a lack of PCR in the triple negative setting, or for triple negative cancers, what we've seen based off of the CREATE-X study is that these patients may benefit from adjuvant capecitabine. And that is something that we are looking to further define within the ER positive basal cohort is will they achieve also the same benefit from this adjuvant capecitabine? So a lot of good information that could be provided with genomic profiling to really further define and add precision to the subtyping and identification of molecular subtypes. And really what I wanted to close with is, in terms of the ability to comprehensively genomically profile. We think Mammogram Blueprint, with the combination of 150 genes, gives you really the most comprehensive profiling available for early stage breast cancer. Not only does it inform the upfront chemotherapy decision or prognostic decision, but also we have with further data that we won't be able to cover in detail, but it can help with not only the chemotherapy decision, but also endocrine decision making, as well as long-term extended endocrine decision making. So really, if you want to go beyond the chemotherapy versus no chemotherapy, really Mammogram Blueprint is really one of the only tests available to help answer this this important clinical question. Okay, and that's what I wanted to share with this group today. Happy to answer any questions at the end of the session.
Thank you so much for thank you so much, Mr. Joe, for the wonderful session. It was indeed very, very informative. So the next speaker of the evening is Dr. Mithun Chacko John. He is a medical oncologist, Jubilee Mission Medical College and Research Center, Thrissur, Kerala. So Dr. Mithun would be discussing on new ways of immunotherapies for breast cancer. Over to you, Dr. Mithun.
Yeah, thanks a lot for the introduction. So let me share my screen. Just a minute. Am I audible?
Yeah, Dr. Mithun.
Yes, sir.
Yeah.
Is my screen being shared?
Yes, sir.
The slides are moving, right?
Yes, sir.
So, yeah. So without much ado, I will directly go to the topic, that is immunotherapy in breast cancer. We all know immunotherapy, I think, is a next big thing, or the future, or at present we can say the present of many cancer treatment, because it is being used. The immune checkpoint inhibitors is being used in almost all cancers. But it was not much being used in breast cancer, but with the recent trial data and recent approval, I think it's high time that we started using immunotherapy, but with a big question mark of the side effect profile as well as the financial toxicity the patients are going to receive with immunotherapy. But definitely, it's going to be the future in the treatment of almost all cancers, including breast cancer. Not all breast cancer, at least a small segment of breast cancer, which may benefit from these patients, from this treatment. So this has already been discussed. It's constituted a major health problem worldwide, and almost 30% of all female cancer cases and 50% of cancer-related deaths. In India, it may be even more. And we all know TNBC is associated with the highest likelihood of distant recurrence and death compared with other subtypes. The TNBC, or the basal subtype, is considered the most aggressive, and considered a systemic disease. Most of them, even early breast cancer, after treatment, after even all the chemotherapy, adjuvant chemotherapy, these patients may metastasize and ultimately cause the death of the patient. So which segment of patient may benefit from an added treatment? Which patients, which segment of breast cancer may benefit from immunotherapy? So as I've discussed earlier, it's considered the new pillar of cancer treatment, almost used in all cancer types, and the most important one is the immune checkpoint inhibitors. What happens is that usually the T lymphocytes should kill the tumor cells. But what happens? The interaction between the PD-1, PD-L1 and the CTLA-4 actually cause the inhibition of the T cell activity against the tumor cells, and the tumor cell kill is not happening. So we have discussed about immunotherapy, which makes the immune system of the patient itself to kill the tumor cells. So there is a shift of focus from the tumor to the tumor microenvironment, the tumor microenvironment, which contain the tumor infiltrating lymphocytes, which actually can cause the tumor cell kill. So success of immunotherapy largely depends on the immunogenic nature of the tumor. So we all know the first immunotherapy initially was used in the highly immunogenic tumors like the malignant melanoma, the RCC, or the non-small cell lung cancer. These are highly immunogenic tumors, and the success of immunotherapy largely depends on the immunogenic nature of the tumor. Traditionally, we all know breast cancer has been considered as an immune silent cancer type. This is basically because more than 60% are ER/PR positive, the luminal A and B type, which are considered as an immune silent type. But there is increasing evidence showing that the breast cancer constitutes a varied variety of tumors with different degree of immunogenicity, mainly the triple negative breast cancer, which is believed to be more immunogenic subtype. The next slide will be showing how it's happening actually. So if you see the tumor infiltrating lymphocytes, if you see the overall, the percentage of tumor infiltrating, comparing the ER positive, the HER2 positive, and the triple negative, that is the ER/PR negative and the HER2 negative, the tumor infiltrating lymphocyte, the percentage is much higher in the triple negative as well as the HER2 positive. But when we compare the ER positive, HER2 negative, which constitutes the majority of the breast cancer patient, the tumor infiltrating lymphocytes are much less. Similarly, the PD-L1 expression, the non-TNBC, it's less when comparing the TNBC. And the tumor mutational burden is much higher in the triple negative or the basal-like breast cancer. So if you see the basal-like breast cancer or the TNBC, which constitutes around 15 to 20% of our breast cancer patient population, it's the tumor infiltrating lymphocytes are high, the PD-L1 expression is high, and the tumor mutational burden is also high. So that's why there is this rationale of using the immune checkpoint inhibition in triple negative breast cancer. So I'll be discussing more about the usage, the data, what is showing by which we can use the immune checkpoint inhibitors in triple negative breast cancer. So basically, I'll be first dealing with the advanced stage triple negative breast cancer. So if you see the checkpoint inhibitors in advanced monotherapy with checkpoint inhibitors, they have got very moderate response rate. If you see the atezolizumab in the first line, we are using monotherapy, the response rates is approximately 24%. And if in the second line or after second line, it's only 6%, considering the monotherapy. And in the pembrolizumab, the keynote trial, if you are using pembrolizumab single agent, in the first line, the response rates are very modest of 21.4%. In second line and beyond, it is 5.3%. But another important point I want to make you all note is that those patients who had responses, that is the complete response and the partial response, even though a small percentage, those patients who had good responses had sustained response. We all know with the treatment of immunotherapy, those patients who have got partial response or a complete response are having durable responses. So they are going to respond to a longer duration of time. So even though the response rates were modest, these patients who responded had a durable response. By seeing the overall survival, those patients who had complete response or a partial response with atezolizumab, the 1 year overall survival in a metastatic setting was 100%. The 2 year overall survival was almost 88%. And the 3 year overall survival was 58%. That's quite a huge number. So those patients who had a very good response had sustained response. Similarly was the experience with pembrolizumab monotherapy as well. Those patients who had good response had sustained durable responses. So what may be the reason? What are the biomarkers? Can we find any biomarkers so that we can select those basal type or triple negative breast cancer who may benefit from the immunotherapy? We are not sure, but definitely guides are there, like the PD-L1. The PD-L1 CPS score of more than 10, they had good overall survival. And if the PD-L1 score increases more than 20, the overall survival further improves. So definitely PD-L1 can be considered a biomarker for the utility of using the immunotherapy monotherapy as well. Now, another one is the tumor mutational burden, which can also be used. it was seen that if the tumor mutational burden, if it's more than 10, more than or equal to 10 mutation per MB, the overall survival was better. There was a trend towards improvement in overall survival, though statistically not significant. But only a very minority of the patients, approximately 10%, had a tumor mutational burden of more than 10. So though a minority, these patients had an improvement, trend towards improvement in overall survival. So these two can be considered as a biomarker, not yet fully validated, but considered as a biomarker for the usage of immunotherapy in breast cancer. Now coming to the combination, the IM Passion 130, this is one of the pioneer trials in which atezolizumab was added the first line nab-paclitaxel in advanced TNBC and found to have a benefit. So in this patient, there's a randomized double-blind placebo-controlled phase 3 trial in which patients with metastatic or inoperable locally advanced TNBC, patient received no prior treatment, were randomized to atezolizumab plus nab-paclitaxel versus placebo plus nab-paclitaxel. And the primary endpoints were PFS as well as overall survival in the intent to treat population and also in the PD-L1 subgroup. So we'll see to the population, the IM, the overall survival by the PD-L1 status. If you see the PD-L1 positive patients had median overall survival of 25 months as against 18 months to the single agent nab-paclitaxel, and in the PD-L1 negative, it was not statistically significant. There was no improvement, 19.7 months versus 19.6 months. So definitely in PD-L1 positive patients, there was a statistically significant improvement in using atezolizumab plus nab-paclitaxel as against the nab-paclitaxel alone. So this is one important, this is one of the landmark trials in which the immunotherapy along with chemotherapy was showing an overall survival benefit, but only in PD-L1 positive patients. There was another trial in this, the nab-paclitaxel was used, another trial in this IM Passion 131, in which the conventional paclitaxel was combined with atezolizumab and it was compared with the conventional paclitaxel alone. But in that trial, it was not found to have any benefit in the overall survival. So that was a negative trial, but definitely the IM Passion 130 in PD-L1 positive, we can think of adding atezolizumab to nab-paclitaxel in PD-L1 positive patients with an improvement in overall survival. This is another trial, Keynote 355 trial, in which the addition of pembrolizumab to first-line chemotherapy in advanced TNBC. Here, if you see, it was chemotherapy, the physician's choice. It can be nab-paclitaxel, it can be the conventional paclitaxel, or it can be gem-carbo. So the investigator choice of chemotherapy was used, and it was combined with pembrolizumab versus pembrolizumab placebo plus chemotherapy. And if you see the intent to treat population, the 6-month PFS was 55 in the combination arm as against 47, and in 1 year it was 29.8 as against 20.9. So there was a trend towards improvement, but the statistical significance was not tested due to the hierarchical testing strategy. And coming to the PFS in PD-L1 positive, this was the primary endpoint. In PD-L1 positive, if you see, there is a very good statistically significant improvement in the combination arm of pembrolizumab plus chemotherapy. Here we can see the 6-month PFS was 65% as against 46.9%, a whopping almost 19% improvement in PFS benefit. And at 1 year, it was 39.1% versus 23.0%. So almost 16.1% improvement in PFS at 1 year in PD-L1 positive patients. So definitely in PD-L1 positive, high-risk patients having a metastatic disease, we can think of adding pembrolizumab to the chemotherapy arm because there is a statistically significant improvement in PFS at 1 year, and that too quite a huge improvement, because we all know the triple negative breast cancer is a very bad disease, and other than the immunotherapy adding to the chemotherapy, we have got only chemotherapy in our armamentarium, and most of the patients succumb to illness in the first year itself. So PFS benefit at 12 months of more, approximately 40% is considered very good in a triple negative segment of negative segment of patient. So immune checkpoint inhibitors, summarizing in advanced TNBC, responses to the immune checkpoint inhibitor in metastatic TNBC monotherapy are modest, but we'll have to think about the line of treatment, the PD-L1 expression, the tumor infiltrating lymphocytes, as well as the tumor mutational burden. Atezolizumab plus nab-paclitaxel has been approved for the first-line treatment in PD-L1 advanced TNBC as per the IM-PASSION 130 trial, but no added efficacy if we are using the paclitaxel, conventional paclitaxel in the chemotherapy backbone as per the IM-PASSION 131. So in PD-L1 positive patients, we can consider adding atezolizumab to nab-paclitaxel according to the IM-PASSION 130 trial, and also according to the keynote trial, pembrolizumab plus chemotherapy can be nab-paclitaxel, it can be paclitaxel or gem-carbo according to the physician's choice, approved for the first-line treatment in PD-L1 positive advanced TNBC. So this is regarding summarizing the use of immune checkpoint inhibitors in advanced. So we all know advanced TNBC, the triple negative breast cancer stage 4 disease is going to fare badly. So those patients who have got a good performance status and who are affording, we should think of adding the immune checkpoint inhibitors to our chemotherapy armamentarium so that the patient can benefit, and patients who benefit may have a sustained benefit with the usage of the immune checkpoint inhibitors. Now coming to the whole controversial thing, the immunotherapy for early stage triple negative breast cancer. So I've discussed earlier, even if you are seeing an early breast cancer, the triple negative, we all know triple negative breast cancer is a systemic disease. We have to hit them hard. So that's why we are giving neoadjuvant chemotherapy for almost all the triple negative breast cancer so that we can achieve pathology complete response. And we all know achieving a pathology complete response, those patients who achieve are going to fare better as compared to those patients who are not achieving a complete pathologic response. So we are giving dose-dense chemotherapy regimen. We are using the capecitabine after the surgery if the patient is not achieving. All these has been to improve the overall survival, the curability of triple negative breast cancer. So what next can be added? Can immunotherapy improve the complete pathologic response or improve the survival of our triple negative breast cancer? So there comes the immunotherapy for early stage triple negative breast cancer patients. So this is a landmark trial in which in the neoadjuvant setting, the pembrolizumab was added to the chemotherapy armamentarium. The chemotherapy was pacli-carbo and then dose the DEC, the doxorubicin or epirubicin and cyclophosphamide. So basically the taxane plus carboplatin and then the EC or AC along with the pembrolizumab or the chemotherapy alone. And these patients will then be receiving a maintenance adjuvant phase pembrolizumab after surgery as against placebo. So what is the benefit of adding the pembrolizumab in the neoadjuvant setting and also in the adjuvant setting? Does it improve the pathologic response? So the primary endpoint in this study, the keynote 522 in the neoadjuvant setting, was definitely complete pathologic complete response by local review, and also EFS, the event-free survival by local review. And if you see the primary endpoint in the intent to treat population, if you are using the combination arm of pembrolizumab plus chemotherapy, the complete pathologic response was huge. There was 64.8% as against 51.2%. We all know when we are giving dose-dense regimen, when we are giving chemotherapy for a triple negative, the complete pathologic response is to the tune of around 40 to 50%. So with the addition of pembrolizumab in the intent to treat population, there was a 14% increase in complete pathologic response, PCR. And if you are seeing the PD-L1 status, the PD-L1 positive patients, the complete pathologic response was around 68.9% as against 54.9% when we are using. So there is a 14% improvement, and the complete pathologic response is reaching almost the tune of around 70% in PD-L1 positive patients by giving neoadjuvant chemotherapy plus pembrolizumab. Whereas in PD-L1 negative patient, it was 45.3% as against 30.3%. So still there is a benefit, but the maximum benefit, the maximum pathologic complete response was seen in those patients who are PD-L1 positive. So definitely this can be tried in those patients who have got at least a locally advanced CA breast, triple negative breast cancer, where we have to go for complete pathologic response, because otherwise these patients are going to fare badly and most of them will develop metastatic disease, and that too in the first year of disease or at the end of first year of disease. So this is regarding the event-free survival. Event-free survival is also much better, 84.5% when we are combining pembrolizumab plus chemotherapy versus 76.8% in the chemotherapy alone arm. So at 3 years, when we are giving pembro plus the chemotherapy, the event-free survival was 84% as against 76%, almost 18%, which is improvement, which was statistically significant. The next one is the IMpassion 031 study, in which atezolizumab was added to the neoadjuvant chemotherapy, atezolizumab plus nab-paclitaxel, weekly nab-paclitaxel, and atezolizumab plus AC, followed with surgery, and a maintenance atezolizumab, as against chemotherapy alone, followed with observation. Here also, if you see, the PCR rates were much higher in the combination arm. The atezolizumab plus chemotherapy had a PCR rate of 58% as against 41% in the chemotherapy alone arm. So definitely there is improvement in pathologic PCR rates when we are adding immunotherapy to the chemotherapy backbone. So this is according to the PD-L1 status. The maximum benefit was seen in PD-L1 positive, almost similar to what we saw in the Keynote trial. The PD-L1 positive, the complete pathologic response reached almost 70%, as against 50% in the placebo plus chemotherapy arm. And in the PD-L1 negative patients, the complete pathologic response in the combination arm was 48% as against 34%. So this is another in which durvalumab, another immunotherapy agent, was combined with the chemotherapy arm. And here also, if you see the pathologic response rate, PCR rates were 53.4% as against 44%, 53 versus 44. And the 3-year overall survival was around 95% as against 83%. So definitely, when we are adding immunotherapy, either pembrolizumab, the durvalumab, these all benefited with the addition, and definitely this benefited more in PD-L1 positive patients. But definitely the benefit comes at the extra cost of the extra side effects, the immune related adverse effects. Majority of them are mild to moderate, but there have been reported of life-threatening or life-threatening adverse effects, immune-related adverse effects, mainly in the form of encephalitis, aseptic meningitis, pancreatitis. So this also has to be taken care. So this, the extra financial toxicity and also the toxicity associated with immune checkpoint inhibitors. Another important point of immune checkpoint inhibitors is that those patients having adverse effects like pneumonitis, the thyroiditis, the colitis, enterocolitis, these patients can have these adverse effects even after stopping the treatment. So even after years after stopping the treatment, these patients can have sustained. So these patients should be selected wisely, because sometimes for curing, so for the extra cure, these patients may be having life-threatening immune-related adverse effects. Definitely the management of immune-related side effects, majority of them, as I've discussed, are mild to moderate, but sometimes may have to give minimal dosage of steroids. We all know steroids can affect the efficacy of immunotherapy, but at lower dosage, the therapeutic efficacy is not affected, and steroid taper has to be done in 4 to 6 weeks. But they can be used, but definitely it has to be selected wise. In the previous talk, we have been discussing about how to reduce the treatment, and now we are thinking of giving extra. Definitely, some patients, around 25 to 30% of patients, may benefit with the use of immunotherapy, but the wise selection of these patients is absolutely necessary, especially those patients who have got a locally advanced, not positive patients, T3 not positive. These patients may benefit because these are the patients who have got the maximum chance of metastasis, and these patients may benefit. PD-L1 positive patients may benefit with the add of pembrolizumab or the durvalumab to the chemotherapy arm. But definitely more data has to come. We have to see the long-term data, because there are more questions than answers actually after these 3 trials. Definitely, the neoadjuvant immunotherapy, does everyone benefit? That's a big question, because the financial toxicity and the immune-related side effects are also much more when compared to the chemotherapy arm. So biomarker selection is quite important, like the PD-L1 tumor mutational burden. So we are using PD-L1, but tumor mutational burden we are not using quite frequently, and the balance risk and cost. So we have to see who will benefit from chemotherapy alone. I think more and more genomic profiling should come to help us, which patients are going to benefit from immunotherapy and which patients may benefit from chemotherapy alone. Definitely, we have to balance the risk and toxicity. So in which patients we can avoid immunotherapy, because I've discussed earlier, some certain side effects of immunotherapy will be there for longer duration. So for many years, these patients may be having adverse effects, especially the pneumonitis part, the colitis part. Hypothyroids, many of my patients are on thyroid, but that's quite manageable actually. And another important question is the combining immunotherapy with PARP inhibitors. So what happens in the BRCA mutant? Do we have to add the PARP inhibitors to the immunotherapy? That's a big question mark. It's yet to be answered. More and more trials has to come. And the optimal duration of immunotherapy in patients who achieved pathologic CR in surgery versus non-pathologic CR. So the impact of adjuvant immunotherapy.
Sorry to interrupt you.
Yeah,
question.
It's last slide.
Okay.
And the chemotherapy backbone we have seen with the pembrolizumab keynote trial, it can be added any chemotherapy, but the optimization has to be done. And also the role of ADC. Actually, sacituzumab govitecan, which is approved in the 3rd line, can be used upfront. Also, the trastuzumab deruxtecan, which can be used in HER2 low type. So these all has to be answered. More and more trials should come. And the post-neoadjuvant therapy, with the CreateX, we have all be using the capecitabine when there is no complete pathologic response. So whether we should add immunotherapy plus capecitabine if we have used immunotherapy. So these all question has to be answered. More and more data should come out. With the present data, with the present trials and with the present data, I think there are more questions than answers in the early stage breast cancer at least. I think with that, I will close my session. Thank you.
Thank you so much, Dr. Mithun, for sharing wonderful insights with respect to use of immunocheckpoint inhibitors in breast cancer patient, mainly in triple negative patient, and highlighting the need of testing PD-L1 and tumor mutation burden. Thank you so much. So can we move on to the Q&A session? Yeah. So the first question is, in case of multifocal ductal carcinoma, how is TNM staging applied, especially with regard to size? So Dr. Gale, would you like to answer this?
Yeah. So with multifocal ductal carcinomas, firstly, the tumor or the tumor component within the mastectomy specimen or whatever specimen is presented to at the time of grossing should be sampled accurately. Because we may miss larger foci of invasive carcinoma. So multifocal carcinoma, those biopsy specimens should be sampled adequately, more than 10 to 15 slices. And then the tumor component, which is invasive, should be measured microscopically if possible. And we should be pragmatic in this approach. And based on the largest invasive component, the TNM staging is given. With the precursor, with the prefix as M. So M means multifocal, and then TNM, stage water based on the size of the invasive carcinoma.
Thank you so much, Dr. Gale. Maybe move on to the next question, please. Yeah. So as for the guidelines for MRI or mammography for high-risk patient, what is the minimum age and what is when it should be started for high-risk group, and of course for general average risk group patient also, if you can highlight. Dr. Atul, you would like to answer this? On this, is Dr. Atul in the meeting? Still in the meeting? Dr. Gale, would you like to take it if
Yeah.
Dr. Atul is not there? Yeah.
I think for high-risk groups, especially those patients who are having family history or BRCA1 mutation association, so those patients are recommended to be started, earlier, because at the age of 30, or that is what is recommended as per the American Society, and 30 years onwards, mammography and MRI can be used, but it should not replace mammography. So I think 30 years.
What should be the interval after once it has been scanned, and what should be the interval as per the guidelines?
Generally they say it's 1 year or up till whatever, every year they need to take a mammography, and up till whenever, the lesion occurs or whenever the patient is healthy.
Okay. And for the average risk group patient?
Average is 40 years.
And for them, the screening should be done intermittently for how long? After 1 year? 1 year only. All right. All right. Thank you so much. So this question is, Dr. Mithun, would you like to add to this?
Yeah, just a point. In very high risk patients, BRCA positive, I think at 25 years, we should start 6 monthly. We should alternate the mammography with MR mammography. The patient is affordable. That is the guidelines actually, because the basal-like or the BRCA positive patients usually have the basal-like breast cancer, and these patients annual mammography won't suffice, because 6 monthly we'll have to get the mammography done. So very high risk patient, what we usually do is start at 25 or 30 years and do every 6 monthly. That is mammography alternating with an MR mammography.
This is the guidelines, NCCN guidelines, or some other?
NCCN guidelines.
NCCN. All right. Thank you so much, Dr. Atul. So the next question is to Mr. Joe McKelley. This is related to this MAMA print and of course blueprint also. So we are analyzing 17 genes in this particular test. So do we get some patients which are in gray zone? Like there is a category, there is a range 0 to -1 or 0 to +1. So low risk or high risk is categorized based on if the patient is falling in whether between 0 to -1 or 0 to +1. So is there the set of patient where patient are falling under gray zone? So what is the recommendation for those patients?
Oh, thank you. Thank you for the question.
Yeah.
Hopefully you can hear. Yeah. So the way the MammaPrint was developed is that you identify 2 definitive groups of high risk and low risk. So within that is that continuum that you mentioned, right around the cut point of 0. There's no clear defined intermediate like there is with other tests. But again, it's a combination of clinical as well as genomic factors. So really for those patients that are really towards the middle of the cut point, I think that it becomes now a patient decision, or it becomes a shared decision. You always have the definitive data between low risk and high risk. So for all of our trials, for our patients low risk, if they're indicated as low risk and the indication for them was to give no chemotherapy, then that's the way that the data was, that's the way the trial was conducted. However, for those patients that are right on the cut point, which is very few, I would say, I think it does become a shared decision, which I think is important for patients. But really, there's no defined gray zone in MammaPrint. Did that answer your question?
Dr. Vinaya, ma'am, can you hear us?
Okay, I think this second question here is for me. I'm not sure if you want me to go ahead and take it, but so what is the sensitivity and specificity of assay for tumor profiling? Really for our test, the way that you define sensitivity and specificity, it's not, it's more along the lines of what is the clinical outcome of these patients, whether they're low or high, and depending on what treatment they receive. So really a more definitive way to look at the performance of our test or test genomic profiling in general is to look at the negative predictive value and positive predictive value. So when you look at it in those terms, so I think the most precise way to look at it is within the context of a clinical trial where the treatment is controlled. For patients that are low risk, indicated not to have any chemotherapy, what is the potential risk of recurrence? That'd be the negative predictive value. And so based off the MindDeck data, what we saw was that for those patients that were mammoprint low risk, despite having clinical high risk features, between patients that received chemo versus no chemo in that randomized group, really the difference or the absolute numerical difference was 1.5%. It was non-significant. So when we look at the NPV or the negative predictive value, that's somewhere in the range of 98.5% NPV. There was this 1.5% numerical difference that was non-significant. And what we see further now is that that is really dependent on age. So for those patients that are postmenopausal, really there's no benefit to chemotherapy for those patients. So the NPV is quite low for a mammoprint low risk with no chemotherapy. Hopefully that answers that question as well.
Yeah, thank you so much, Mr. Joe.
Welcome.
Do we have more questions?
Ma'am, because we have exceeded time, ma'am, we'll request you to please.
All right, thank you so much. So on behalf of Onco's Laboratories Limited, I would like to thank our speakers for the enlightening and enriching session. As you may be aware that Oncos is a leading diagnostic player when it comes to specialized testing. We have a pan-India network with over 20 years of experience in specialized testing. We believe in continuous knowledge sharing and education and remain committed to providing the best-in-class support to clinicians. Looking forward to be having more such sessions and interactions in future as well. Once again, thank you all for your presence. Last but not the least, thanks to Team Marketing, Oncos Laboratories Limited and Kavina Creations for the excellent coordination and